Good morning, ladies and gentlemen. At the outset, I would like to extend my respects and pronounce to this luminary surgeon, Padma Shri Professor Jaipal Singh. I thank the ASI for giving me this opportunity to deliver this oration held in his memory. I'm sure as a teacher par excellence, he would have really liked this subject, surgical mentoring, need of the hour. What I would like to do is bring to your notice the current situation in our postgraduate training, mention a few things about what mentoring involves, share my personal experience, and perhaps say a few words about how we could take this process of mentoring further in our country. The current situation is one of great difficulty. If you look at the goals of any surgical training, it is to let loose on society a competent surgeon who practices ethical and sound surgery. The reality is that recently we've had a huge increase in the number of postgraduate and undergraduate seats in the country, and the process is continuing, and the government is expanding this student base even further. But the actual fact is that the infrastructure has not kept pace with this increase. The number of patients have not really increased. And one of the professors I know in my town had this confession quite recently, and I quote him, "I can't even recognize my PGs in my own unit. There are 40 of them. How can I train them?" And so the result is obvious. Even after passing MS or the DNB, our graduates are incapable of doing the simplest of procedures. And this is a huge setback because surgery is basically a skill-based science. So to meet the goals of surgical training, surgical mentoring is the need of the hour. Let's learn a few things about what mentoring is. There are many definitions for mentoring. This is my favorite, where it says that an experienced surgeon helps the mentee, the trainee, in re-examination of their own idea of learning, personal and professional development. Please note that this is not a didactic kind of teaching, but you're encouraging the trainee or the mentee to think for himself and further his own skills and his career. In that sense, a mentor is a facilitator. So mentoring goes well beyond teaching practical steps in surgery. Cognitive skills, that is the academic part of surgery, and psychomotor skills, the actual operating skills are there. But then you go well beyond that in terms of social skills, where you help them with networking, you help them with communication skills, and professional skills, where you help them get jobs and manage their finances and the like. Mentoring can be by individuals, just by themselves, standalone mentors like me. It could be encouraged in institutions, or even major organizations like the ASI, for example, can undertake a mentoring program. It could be formal or informal. Formal, where it is completely following a set of rules, but informal, which is what I do, which follows a pattern but doesn't have written down, laid down rules. These rules may be actually written down as a form of an MOU, which the mentor or the institution and the mentee sign and follow, or it could be without an MOU. It could be completely structured, where everybody falls in line and the mentor and the mentee do the required thing and meet goals and assessments and things like that. It could also be unstructured. And honestly, while these written down rules and structure is to some extent important, it is not mandatory, because a well meaning mentor and a responsible mentee can still have a very successful mentoring program without these written instructions. Whatever pattern you follow, the principles remain the same. The important thing is that there must be a clear cut goal setting. In my practice, for example, in terms of academic excellence, we insist that the people read up about what they are doing, why they are doing, and shows the evidence for what we're doing is right. In terms of psychomotor skills, for example, uh, in the laparoscopy, I can give the whole details, but for the lack of time, I'll tell you a brief overview of what we insist. At the end of 1 year of mentoring with us, they should be independently able to do safely an uncomplicated inguinal hernia, a ventral hernia, a gallbladder, and an appendix. They will be able to do more things as well, but this is an absolute requirement. Now, to achieve this, the mentor must be invested, completely committed in helping the mentee get this required skill development, encourage them with references and the patterns of reading and writing papers. There must be some clear cut path towards what happens after the year of mentoring, for example, which is career guidance, and also help them with soft skills like communication with the patients, communications with the colleagues, and live the life of ethical surgery so that they understand what ethics is. You don't formally teach it, but they just follow what you do and learn the ropes in as far as ethical practice is concerned. There is a lot of responsibility that is expected of the mentee as well. It's not a one-sided relationship. It takes two to tango. He has to take initiative in learning. You can't spoon feed these people at this level. They have to learn for themselves, take the initiative, ask questions, um, offer to work hard and do more and learn the ropes of surgery. And he must be a responsible learner, particularly in terms of responsibility in patient care. It's obvious that if the mentee is primarily a responsible person looking after the patient well, the consultant's patient well, the consultant or the mentor would be motivated to help this youngster. It is clearly proven by many, many studies. I have quoted a few of them here, that the mentorship program has many, many advantages. It has certain disadvantages too, and we'll touch upon them. There is no doubt that the technical skills are improved in a mentee so that he can do a safe surgery, and the learning curve is much, much faster than otherwise. They learn to handle complex problems, complex surgical issues. It's also shown that the patient outcomes are better when there is a mentorship program. There will be more academic productivity. For example, one of my mentees managed to get 9 papers published within 2 years. He was very motivated and we really had more time. It was during the COVID period. So our clinical workload was not much. And so he managed to get 9 papers out. And it's also shown that in a good mentorship program, the mentee learns about work-life balance, his growth, and his well-being as well. And it reduces burnout. In terms of disadvantages, the real main issue is that operations take 30 to 40% longer when there is a mentee being trained at the time of surgery. Now, in private practice, this may cost more because some hospitals have the habit of charging the operation theater fee in terms of the time taken. Of course, there is no motivation anywhere, for example, where the mentor gets compensated and it may be working on one's mind. And in rare instances, you may have a problem with the mentor-mentee relationship where one may not get along with the other. But generally, this doesn't happen. I must mention about toxic mentoring. In certain situations, there can be an actual exploitation of the mentee. He may be just used as a pair of hands, and these are all an absolute no-no in a mentorship program. You have to look at them and treat them as your own child, for example. There may be a lot of hierarchy where the mentee is not allowed to have any independent thinking. He may be snubbed when he suggests something, and that is not really correct. There may be bias as well, particularly gender bias and regional bias. You know, mentor from the south and a mentee from the north, and things like that, and failure to credit. This happens, I think, more often than we acknowledge, where the mentee has done all the work, all the hard work, and done the statistics, and has written a paper, for example, happens mostly in the academic scenario, where the credit for his work is actually usurped by the mentor, and that is an extremely incorrect situation. Now, if you want to look at how well the mentorship program is going on, you may have a formal assessment. It can take many forms. There can be regular meetings and check-ins. There can be a feedback from both the mentor and the mentee. And an independent person may actually have a performance assessment as well. It doesn't happen in my practice. It's a one-to-one relationship, but we have regular meetings, very informal meetings between cases. We check, I personally check if the mentee is happy and getting what he or she expected from the program. Psychomotor skills are the primary goal in the mentorship program, because that's where the mentee has to learn a lot. It's known that the learning of skills occurs in a few steps. First, you must mention the objective. You must show how. One of the difficult skills to learn, for example, is laparoscopic suturing. So we tell them what to do, how to do it, and how to achieve it. We show it to them. We ask them to do it. And as they're doing it, you're standing next to them. We give them an immediate feedback. This immediate feedback is considered very, very important. And then you allow them to practice. The practice may be on a lepro trainer, for example. Usually practice on a patient would be very time consuming and perhaps a little unsafe. So they practice it and then try and do it in vivo. The telementoring is something that is quite possible for people who have reached a certain stage where they just need certain polishing of their skills, and they may not be physically present. I have no personal experience of telementoring, and I'm not going to talk about it anymore on this occasion, but it is something that one can consider. I'm showing you a few photographs of how we actually show it. I'm showing my mentee who is standing to my left, the skill or the methods or steps in a laparoscopic suturing. Here, I've asked her to put a Veris needle in. I'm standing right next to her. When the suturing occurs, for example, when she has some struggle in loading the needle or doing any of those maneuvers, we actually hold hands and help them do it so that they get the confidence and they don't get frustrated. And when they reach a certain stage, in keeping with the concept of graded responsibility, we allow them to do the procedure. But as you can see, I'm stood right next to them. It's never happened where I have left the whole thing to my mentee and gone away, gone out of the OT. So I'm always standing next to them, scrubbed most of the time. But at times when the person has learned well, I want them to do it by themselves, and I don't want to be breathing down their necks. And so I just stand next to them quietly and watch them and raise an issue only if they're doing some move which may be potentially dangerous. So who should do the mentoring? Who should take the responsibility of the mentoring? I think by now I have established that there's a huge need for mentoring. Uh, then if you really have to answer this question, you have to look at the other reality in our country. We spend only 1.9% of our GDP. Compare that with the 17% in the US and about 10% in the European Union. And so it is clear that most of the work has to be done by the private sector in India. And the fact bears that out, because 85% of all inpatient work, surgical work, is done in the private sector, which means that every one of us, either in the government sector or in the private sector, have to consider being a mentor. Then that raises its own question. Patient has come to you, has paid for your services, recognizing your standing as a surgeon. How can you justify mentoring in private practice? Now, this is to understand this and to justify it. I think we have to go back to the history of surgical training. The Halstedian model of residency is considered the forerunner of all training programs. At that time, those people who were not paying, called the indigenous patients, were the ones that the apprentices trained on. But over a period of a few decades, and in fact, a century, it's now considered unethical to restrict training only to non-paying patients. The other problem that occurred, particularly in the United States, was that when the trainees were being trained, the consultants were accused of ghost surgery, which means that they were accused of taking money and getting somebody else to operate. And then ACS in the 1970s, for example, went out of the way to prove to the world, prove to the patient population that this was about training, where they had to train and get the next generation of surgeons to do safe surgery. And they went on to say that they have instituted many safeguards where, when supervised, a resident training is not a danger to the patient. And that has been borne out by many, many studies, and I quote two of them. There are two caveats that has to be stressed. One, there must be direct supervision. That means you are standing next to the trainee or the mentee, and there must be some degree of case selection. Large majority of our patients do not have huge comorbidities or do not have very difficult surgical issues. So such people can be trained. And you can see that in this retrospective study of 362 patients of emergency colorectal surgery, there was no difference in leak rates or mortality between consultants and trainees. And in this big meta-analysis with 182 studies and 144,000 patients, there was no difference in major complications. So minor complications like wound infections and a slightly longer stay in hospital were seen when the resident population had operated on these patients. I would like to share my experience of what's been happening since 2004 in my own practice. I've had 22 mentees. Two of them left before time for whatever reason. Two of them were from abroad. 20 of them were Indians. An equal mix of MS and DNB trainees. Most of them have published a paper in their 1 year with me. Most of them spent 1 year. Some of them spent a little longer. They have published a paper in a peer-reviewed journal. All of them have been placed well. They've never struggled to find some opening after spending that year with me. Unfortunately, one young man died of a chronic myeloid leukemia. The Ethiopians, in particular, have set up very successful laparoscopy units in their own hospitals. Both of them from northern Ethiopia, one from Mekelle and another one from a place called Gondar. Two of them have gone to UK. They now have the potential to be consultants there, but I'm told they're interested in coming back. And two of them have actually become my fellow consultants. They actually are being groomed to take over from me once I hang up my boots. This is Muhammad from Ethiopia. You can see that we were on a trek and he's actually very enthusiastically trekking in the Western Ghats. Just to quote two of them who have been my mentees, it is interesting to see where their perspective comes from. Apart from teaching decision making and technical skills, Vibha gave a lot of importance to being honest, and she appreciated the fact that they were treated with respect. Ajay was very, perhaps I worked him or drove him too hard. So he was gently suggesting that he would like me to consider discussing work life balance with the mentee. Maybe I didn't do it enough with him. I thought I had, but I was obviously not right. But please note, it's not that only the mentee is being benefited, the mentor is enormously benefited in my view. It helps me being with these youngsters who are reading all the time, taking exams and things like that, writing papers. It keeps me keep abreast of the developments. They go and see other surgeons, they attend conferences more than me, and then they come back and give me little tips which I can learn and do my surgery better than before. And they are a huge source of reference when they are still learning and they have major operations which they are not really doing by themselves. They ask me to do it. And once you know that you have a good program going and that you have mentees who will run the unit for you, practically many other hospitals, ask us to go and set up units there. So these are not small advantages. There are many social aspects of mentoring as well. You can see that we go on holidays and take treks and the like. We have regular departmental lunch or dinner. You can see this young man, Nishant, is now one of my fellow consultants. He spent 2.5 years with me as a mentee. This young man, Atmaram, is also the second fellow consultant. This is Ray from Ethiopia. He is with one of my teammates who is actually a physician, but who helped me as my camera person for more than 2 decades. This is Arushi. We're celebrating her birthday here. This is my mentee Sunil with his wife. They come and have a dinner with us, and we have these dinners from our DNB students and my mentees once a year. This is my current mentee, Pavitra, celebrating her colleague's birthday actually. And when we give a farewell, when the mentees leave us, we go out for a lunch or a dinner and give them an informal farewell. I think we now have very clear idea of how socially and professionally this mentee mentor relationship is mutually beneficial and it does good for the system. How can we take it forward is the final question. I think each one of us consultants, irrespective of whether we are in a teaching institution or not, whether we are in a big metropolis or in a small hospital, it doesn't matter as long as we're doing a reasonable amount of work, 30, 40, 50 cases even a month would be enough. You just have to make up your mind to be a mentor. You must pay them well. I think it wouldn't be beyond the hospital or even the individual. I used to pay from my own earnings in the earlier part, in the last 4 to 5 years. My hospital pays them a registrar's stipend. Institutions must encourage their consultants and, if not compensate them monetarily, at least encourage them to have mentees so that it helps institution as well. And perhaps organizations like ASI can institute a formal program and coordinating a matching process. It's all happening at a very informal level now. But perhaps there could be a regular matching process where the mentor and the mentee can be made, can be matched, and regular placements can be made. Ladies and gentlemen, thank you very much for your patient listening. I give my pranams to this great surgeon again. Thank you.